I was jamming to that. That's my first time playing that live. So, I was jamming to it a little bit. Hold on, I got to run it back real quick because it looked good. All right. Well, I see we rolling. Good morning, good afternoon, depending on where you are. We are live for the first inaugural episode of the Survey Readiness Podcast. I am your host, Dr. Kirk, and this is the Survey Readiness Podcast, a bi-weekly podcast dedicated to one thing, helping post-acute care leaders understand survey readiness the way it actually works, not the way we wish it worked. Oh, that's every 2 weeks. We'll break down real 2567s, recurring F tags, leadership and compliance failures, and the survey prep myths that continue to get facilities cited. Sometimes I'll bring guests. Sometimes it'll be me walking through what the surveyors are seeing and finding. And I'm gonna be honest, it's going to be very opinionated at times. This podcast is educational. As I've stated, it will be opinionated at some time, but I'm honest, I'm firm, and grounded in real survey outcomes. In today's groundbreaking episode, we're going to break down CMS's two recent memos. They released two memos this month in January. Well, technically it is February now. So last month that every administrator, DON, and regional leader needs to understand. One reshapes how surveys are conducted and reinforced. The others tighten special focus facilities. So we're going to talk about it. Joining me today is the gym, Miss Veronica Ceaser, MBA, MSN, RN, LNHA, GERO-BC certified, RAC certified. She is a nationally recognized long-term care consultant, speaker, and educator with deep expertise in survey readiness, quality measures, reimbursement strategy. She serves as the VP of clinical reimbursement for multiple facilities in long-term care for a long-term care organization, and is the founder, CEO, creator of Gem Healthcare Consulting, a nurse-owned firm focused on survey survival, quality, and documentation excellence. Veronica is known for her ability to take complex CMX guidance and turn them into clear, actionable strengths that frontline teams can actually use. Her work helps facilities strengthen systems, reduce risks, and sustain quality before surveyors ever walk through the door. Now, today, we're walking you through these memos, what they really mean, how surveyors would think, how you should be acting different. This is where leadership teams are most exposed and why survey readiness now lives far beyond the day of survey. If you're an administrator, a compliance officer, a DON, an owner, a regional, you won't want to miss this. This is the episode for you. This is the inaugural episode of the Survey Readiness Podcast. Now, I would be remiss if I didn't give a shout out to our special sponsor who is sponsoring this episode, who is making this all happen, and that is SurveyGuard. SurveyGuard is the compliance platform for the post-acute care space. If you don't know about it, visit surveyguard.com. Enough with me rattling. Veronica, let's talk about it. How you doing today?
Hey. Good morning to you. Good afternoon to me over in Central Time Zone. I'm looking forward to this discussion. I'm very passionate about survey prep, survey readiness. My saying is stay ready so you don't have to get ready, right? And so this is something that we should be doing every day, not just when we're in window. Yep. Or, we get that call over the intercom that status walked in or that text message thread, but something that we should be incorporating every day.
So that's why we call this the Survey Readiness Podcast, because this is, once again, the first inaugural Survey Readiness Podcast. And I think it's important for us to talk about what survey readiness is, because I think there's a difference between like prep readiness and truly the outcomes that we get from it. And, when we talk about survey readiness, to me, it includes doing a mock survey, finding your deficiencies, prepping for survey, making sure you have all your documentations ready to review and ready to be presented as if it was a survey. I think survey prep is kind of doing one-off things. When I hear people say I'm doing survey prep, it's like, okay, well, I looked at my facility plan and I looked at my quality plan, and that was the prep I've done. But readiness is a continuous state. I don't know if that's how you feel. It's how I view it. What's your thoughts?
I definitely feel that way. When you talk about mock survey, I see a lot of teams will do one mock survey and then kind of we did it, it's checked off. But if you're doing mock survey, it's definitely important to do the mock survey, share the findings with your team, develop a 2567, implement those improvement efforts, and then turn right back around maybe every quarter you're doing that mock survey. Because you know what happens, we do the mock survey, we do the correction right away, and then we go back to business as usual, right? And it's like if state walks in 6 or 7 months after your last mock survey, have we still been incorporating those survey preparation or whatever that we found during our mock survey? So it's important that it's a continuous cycle of improvement. Exactly.
And it's, you mentioned, right, doing your own 2567 and then taking it to QAPI, right? And those past non-compliance, some states accept them, some states don't. Take it for what it is. Once again, let me put the disclaimer on it because I didn't put it in intro. We're live, so I can always add that disclaimer. This is for educational purposes only. You have not retained myself or Gym Scout. You have not retained SMK Medical to assist you with it. So this is for educational purposes only. But I encourage you to write a past non-compliance and take it to QAPI. Is that something you do once you find a deficiency?
Yes, most definitely. And then, we both love QAPI. We speak about QAPI a lot offline. I'm nerd out about QAPI, but my main QAPI pointer or guide is to bring every level of staff into your QAPI. QAPI is oftentimes seen by your frontline staff as like this secret meeting where all the administrative staff go in to the conference room and all they know is they're in there for a couple hours. They may order lunch, but it's important that everybody in your facility understands the QAPI process, from your CNAs, your housekeeper. Every person in the facility should be included in QAPI, and maybe, just alternating some of your frontline staff being included in your QAPI process, in your QAPI meetings. It's always a great thing to have those fresh set of eyes, or those eyes that see the resident care areas, those resident areas, or the resident themselves every day. So I definitely encourage QAPI not to be some secret corporate level or administrative high level secret meeting. Definitely bring in those frontline staff in, and then them understanding the importance and the purpose of QAPI, right?
Yeah. And, first of all, QAPI says you should have a resident or family participation. So I don't know how it's secretive behind a closed door, but I can't tell you how many times it's secretive behind a closed door. The buildings don't understand what you're QAPI. And so when the state comes in and asks, how are you participating in QAPI? The staff throw their hands up and say, well, let me get my manager. I don't know the answer to that question. And the state's looking at it like, this is a basic question. If you're involved, you should know what it is. So I have seen, and I'm not going to say I endorse it or not, but I have seen in buildings kind of put up a QAPI wall in a break room. This is what we're working on. But I've also heard the argument that people say, well, we don't do that because we don't want, it invites the state to ask questions. And I think I can see it both ways. I think it shows that you're transparent about the data. And transparency means a lot in this space that we are in. I mean, it means a lot. So as somebody like yourself, you're a VP, you're over, X amount of nursing homes. How do you ensure that QAPI is getting done appropriately? Because that's called out in this memo as well, right? That we're going to get ready to go into. But how do you make sure your buildings are actually doing QAPI and not just paper compliant?
That's an everyday struggle, right? And so I try to attend QAPI as I'm able, but just also providing the education and just the enthusiasm, right? I know we're both pretty enthusiastic about QAPI. And so sometimes, I get the eye rolls, but as I continue to drill down the importance of QAPI, I feel like I'm getting some buy-in from our staff, from our facilities. And then again, like you said, we do share. I have worked with also some consulting clients that we share some of our QAPI projects, maybe not the specific goals or numbers, but if we're working on falls, we may have, it's fall, don't fall for the fall season. Perhaps that was our third quarter or fourth quarter QAPI project, right? Our focus. And so at least when surveyors come in, they're also able to say, what, do you know about the QAPI? And they might not know the high level, but they can say, you know what, we're working on falls, or our QAPI project, one of them is falls, right? And so they have an idea. We don't bog them down with too many of the the minute details, right? We're not going to get them in the weeds, but at least they have an understanding of what QAPI means, right? You don't want a surveyor coming in and saying, hey, can you tell me about your facility QAPI program? And they're like, what? So just definitely including, our frontline staff and the enthusiasm. I definitely think not making it such a, robotic compliance check off paper meeting, but let's talk about the improvements and let's share the improvements, right? So as we have those little improvements, right? Last quarter we had a 10% fall rate. And this quarter we're at 8.9. Like we know those improvements are not going to be, how quality improvement is a quarter over quarter, time over time. It's not a quick process. And so it's important to share those small victories so that you can kind of get your staff on board and just encourage them, because it is a long process. And I've seen facilities kind of give up. They think after 2 or 3 quarters, we haven't seen much movement. It may have been a 1 or 2% change, but to them, it's not enough, and they kind of abandon it. Well, we're putting all this work in.
So this is where data comes in, right? Because a lot of people are copying things that's not data related. Let's just call a spade, right? Yes. They had one fall and said, we copied it. Well, first of all, we should be looking for trends, at least 3 months of trends, 3 months of data. And we know that sometimes the data is dirty because data is living in binders. And that's a lot of the reason why they're not seeing what they need, right? Where our collection process has failed. We're not collecting. Our analyzation process has failed, right? Maybe it's failing because the person doing the analyzation doesn't want to be in trouble, right? So it looks good, right? So there's so many reasons why QAPI fail, and that's a whole episode in itself. But it leads to, when our QAPIs fail, it leads to this new memo that we got out. And I want to start with this first memo we got out. I actually, shout out to you. I usually am on my game and looking at CMS websites, but apparently I took a Friday off and you beat me to it. And I was like, hold on, what? So I had to go back and take a look at this memo. And this memo that I have on the screen, 310 pages, by the way.
Now, I did not read all 310 pages.
Oh, yes, baby, so. I did. Because you just got to look at what's read.
Yes.
So this memo talked very much about IJs. And one of the things that stuck out to me is now the line of discharging a resident to an unsafe environment will result in the IJ. I'm just saying, if you ain't read this memo, and it talks about what an IJ is, we need to be mindful of that. And it kind of made it very easy here on this page 4 as to what it is that they've made changes to. So you're able to kind of come in here and make it really easy. But let's talk about it, because we have seen discharges that have went to unsafe facilities. We've seen it, for whatever reason, right? And I think that as an administrator, as a regional, as a TOEN, sometimes you have to get rid of you have to discharge the resident, and it may not be the safest place. But I think what's interesting is what they consider unsafe facilities, because it's very subjective. If the member, because we see this all the time, I can say it, I'm not in the building, but if the member was previously homeless and you discharged to a safe homeless shelter, is that considered unsafe? If that was their home-like environment before, are you expected to find this person a house and get them DHS support? Right. So what is your thoughts on that? This IJ now being considered for unsafe environments?
I think documentation is going to be the name of the game. And then also pre-admission. We need to be, we always say discharge planning starts upon admission, but this new memo highlights the importance of, before we even accept this admission, right? Are we able to, one, care for the admission? Because of course, we get those behaviors in, and then we're trying to send them to the hospital or find another place, or like you spoke about.
It's when we're trying to keep heads in the bed. Just because you got a head in the bed doesn't mean it's pan head, and doesn't mean it's a head that you want. If it's going to disturb the milieu, it wasn't worth it. Sorry.
It's definitely looking at that big picture. So definitely making sure that you have enough information. I've seen those referrals with 2 or 3 pages. I want the social history. I want, where they, so I've seen those referrals come in. It's 3 pages of meds and diagnosis. And they say, oh, they have XYZ insurance. Let's take them. And it's like, wait, let's take a look and see, you know, what is the discharge plan? What are the goals for the resident? And so even maybe identifying those goals, right? Perhaps the resident is okay being homeless. They have a history of being homeless. They have certain shelters or they live in a motel prior to whatever this illness is. And their goal is to return to that. But let's make sure that that's documented upon admission, right? And so just having really discharge planning at the start of the admission. We definitely pre-admission actually. And so just knowing, you know, like I said, the residents' goals for discharge, because their goal could definitely be, you know, I'm used to this homeless shelter. My friends are there. I know the staff there, or I've been living in this motel for 6 months, or whatever the case may be. But just making sure it's documented. And that's going to take IDT process. You know, a lot of times we have to get that social service in, even the admissions person in, maybe doing those visits and asking, hey, so what are your goals, you know, after discharge, right? And then we can have a clue of that when they come in and make sure it's documented. So we have that documentation.
You know, I think what you called out is documentation is going to be a big thing. And it talked about documentation a lot in this new memo, especially from the standpoints of a POC. And we will definitely get to that because I think it's something that we need to talk about. What's important to note is IJ doesn't actually require harm. Right. It's the likelihood of serious harm. And I think people fail to realize that, right? It doesn't have to be harm that actually happened. It's the likelihood, more likely than not, as they say in the court of law, right? More likely than not to happen. And administrators, you have to be mindful of that. So if your leadership team can't show it in documentation, more than likely you're going to have an issue with an immediate jeopardy. And I think that that's something that we as leaders have to be mindful of. So the standard of things are there for immediate jeopardy. This is something that the CMS added on. And once again, they did not change the rules. They just changed the consequences. You could never discharge to an unsafe environment. Let's be clear. That was never the place, right? It's just now the consequences are a little bit more stricter. And so leading to that, they revamped how they do their intake and investigation, right? They want to be a little bit more faster. We've all been there. We get an IJ and it's 9 months ago. I think you might have a few thoughts on that.
Listen, I just had one. Okay, it was in July,
and this is February, right? And so I remember us talking, and you was like, "How?" Right? But once again, it's the likelihood, and I think what people don't understand is, right. And I was talking to a lawyer yesterday, and he was talking about he deals with IJs and IDRs and things like that, and kind of the process that he goes through, and it starts from the time that it's identified, and then on the day that they come in and review it, if that situation's still there, you haven't rectified it, they can drag that IJ all the way through, right? We have per day and we have per instance. And I think that's something that people don't understand, the difference between per day and per instance, right? So when you talk about the particular IJ that you've served on or seen, you know, it can go for some 100, 200 days. Am I right?
Yes. Yes.
And so that's... quickly.
Yes.
And that's where buildings get in trouble. I previously worked at a building. That building's no longer actually closed that building down. It's not a secret. You can look up my closure plan. Just type Demetrius Kirk into Google with closure plan right after, and you can see the closure plans I've assisted with. $1 million citation, $1 million survey, right? And it's because buildings weren't using data to drive quality. They weren't doing data with their mock survey. And I have a whole keynote presentation that's getting ready to come out on that, right? We've always done it that way. Well, surveyors don't care about that.
No.
They don't care about that. So they did talk about a little bit about plan of corrections, how now they're going to be a little bit more scrutinizing on plan of corrections. I see everybody using AI for plan of corrections, right? SurveyGuard has a smart POC built right into it, but it's been trained on hundreds of POCs. When you're writing a POC, it can't be cookie cutter. It can't be...
No.
You gotta address the issues that they called out, right? So
and you have to be realistic, right? You cannot put in these fantasy utopia monitoring. We will monitor, we will inspect, we will audit, and then you get caught figuratively with your pants down when they come back and you haven't been able to do any of the things that you said you were going to do in your POC. So it needs to be realistic. It needs to be something that you know that you and your facility and your team can do, right? And so I see a lot of facilities get in trouble when they say, okay, this is the POC, or maybe they have a corporate person who maybe hasn't been in their building in a long time, but they write all the POCs. And they don't know how to build and set up. They don't know, so it's important to make sure the people who are going to actually be doing those audits, those trainings, those in-services are involved in the POC creation. Definitely.
So I have on yo-yo compliance is dead. You can't be halfway over here, whole over here. You got to be compliant 100% of the time, and that's what CMS is looking for. So when we talk about writing these plan of corrections, right, here's some of the things that I tell people to take out. Stop saying all. Stop saying 100% unless you actually mean 100%. Oh my gosh. Don't list residents by name in your POC because it will get kicked back. Am I right or wrong?
Yes.
And it must be based on like a smart, what do they call it? A SMART goal.
Yes.
Specific, measurable, obtainable, realistic, time sensitive.
Yes.
I mean, what else? If you can make it a SMART goal, more likely than not, your plan of correction will be approved. But you don't want to make it, like you said, some fantasy utopia where you said, I'm going to audit 100% of residents for 8 weeks straight. Well, all it takes is to miss one.
Mm-hmm. CMS is like, they have like spidey senses or something, right? Because they always find that one. You could have 99.9%. They will always find that one thing. And it's like, how? So exactly, yes.
And so, what are some things as a regional, right? You covered hundreds of POCs. What are some common errors you see as a regional when you are working with people and they're writing their POCs and you're just like, come on, we can't do this. We can't say that.
I definitely agree with the 100% audit. I also think in-servicing, when you say all staff in-service, right? And then you cannot provide documentation of what the in-service actually included. So you'll have maybe a paragraph, right? Or I've seen in-services have one line, care planning. And then they have 100 signatures, right? It's like, what did we talk about with care planning? Or, the elopement, that's the in-service. But literally, it's maybe 2 sentences.
Yep.
And then staff signatures. And so you cannot prove what you have in service. I'm pretty sure I've seen facilities go around and say, sign this in service. This is an in service about care planning. So that is not the way to improve outcomes, improve quality. Like you just talked about, we're getting beyond compliance, beyond the checkbox, because you haven't really implemented any processes that are going to improve your care planning process or outcomes, right? It's a checklist, and then tomorrow they're going to forget about it.
Facts. And so the new memo had 38 different things that they will accept as a plan of correction. 38 different things. So let me just call out some of them here that I wrote down specifically. For proof of evidence, right, they are looking at your audit tools, completed audits in review and line by line. Your monitoring logs, your QAPI minutes will be sufficient. Any write-ups that you've done, maybe a termination, maybe a reporting, a police report will be accepted as sustained compliance over time. Now, what no longer works is generic statements, as you just called out, or just policy updates with no implementation. They love to say we reviewed and updated the policy, but then there was no education of the policy to the team. So you reviewed it with yourself, you educated yourself, but you failed to update your team. And then one-time fixes without monitoring. Once again, they called out 38 different things, 38 different things that you can do to prove compliance. And I challenge people to really look at it and say, okay, are we doing these things? Because once again, we all have a binder somewhere, and I hate binders. If you don't know, I hate binders. Have a thing for. So we all have binders somewhere, and then when they come in and they look at this binder, once again, it's not compliant, right? So as a regional, How do you ensure that these plan of corrections that you are submitting to the state are compliant? Because there's plenty of regionals that's going to be listening to this and struggle to make sure their buildings are compliant with their POCs. You can't be everywhere at once, right? You may have
Being involved in the process, though, is the number one thing, right? And so it may take education or, just collaboration with that facility administrator, DON, as we are identifying the ways to be in compliance, as we develop the audit tools, as we develop policy changes, policy implementations, or even the in-servicing, right? You want to let them know, because you having that experience, we want to walk and guide them through that. And it's not just the do the POC and we're done, right? It's not just we've submitted the POC, it's been accepted, and that's it. Because they're going to come back, right? They're going to have a revisit and they're going to look at your stuff. So it's important that we take them by the hand through the process. We're not just saying, okay, we got the POC off. Okay, our plan of correction was accepted. See you later. I'm on to the next building. It's going to take ongoing collaboration with the team.
And you can see my screen here. I mean, this is a nice list, and it says, but not limited to, right? Staff termination letters, new or revised policies, photos. And we're gonna talk about photos in a minute, because the surveyors fighting back. They're taking photos now. Revised shower schedule, bathing schedule, right? Documentation of the grievance resolution, new physician orders. I mean, this is a thorough list. So when I see somebody say something vague, I'm like, bro, just go back to the list. They telling you what they're looking for. Once again, they're giving you the answers to the test. Like, right?
Yeah.
They're giving you the answers to it. So I think it's important that we as leaders understand how to write a plan of correction and understand the value of good documentation. You started off the conversation with that good documentation. So one of the things that comes out of that citation is the fact that CMS will, do increased auditing. And that's one of the things that the memo called out, is that, and I didn't know there was a percentage, 10% of their surveys have to be done off hours. And 50% of that 10%, which is it's statistics, 50% of that 10% has to be done on a weekend before 6 a.m. or after 5 p.m. Yeah. So it's mind blowing, and it goes to the importance of survey readiness, right? And versus survey prep. Survey prep is a one-time thing. We want to be survey ready, because when they come after 5 p.m. on Sunday, none of your leadership is there. Your team needs to know what to do. When they come 5 o'clock in the morning, your leadership team ain't there. They need to know what to do, and that's the difference between survey prep, which is one-off, and survey readiness. I was surveyed at 6 p.m. on a Sunday.
The last annual I was involved in, they showed up at 6 p.m. on a Sunday. Actually, I think it was
on a Sunday. My DON was in another state. I was back in Michigan at a baseball game. I was doing something else, not too far away, but I wasn't in a position where I can ready to leave. So it was the most, like, I'm calling everybody, and you got to come in. And I couldn't fault people who couldn't, because this is bedtime. They're putting their kids to sleep. It's 6 p.m. They out of state, and I don't require my leadership team to be, oh, you can't go, right? I'm in Michigan. They drove to Ohio to a game. They can go 4 or 5 hours. They can go wherever. It's who thinks somebody's coming in at 6 o'clock on a Sunday?
Right.
But it's important, right? Because once again, we talk about survey readiness. So this memo covered so much information. But one of the things I think I don't want people to skip over, because you said you missed it. So it was the photo section. Baby, they have a whole section in this memo. Just go to it, type photo. A whole section in this memo that says the surveyors can take photos of deficiencies. The game is changing. Imagine getting a plan of correction and there's a photo of the med room looking disheveled. Imagine that.
It's no longer going to be our word against yours. Now they encouraging the photos, like you said. It's definitely yes.
It's going to change. So I took some notes on it. Give me 1 second. Let me pull it up. Let me find where my notes are. Photo. So photographs. Surveyors can take photos, and it matters now. What surveyors can photo? environmental health concerns, unsafe condition, equipment issues, resident room setups, signage that should be there that's not there. It should say oxygen in this room, no smoking, and you don't have a sign. Go ahead and IDR that if you want to.
It's definitely gonna be a mindset shift, right? Because we used to, we've always done it this way. We'll explain it if they ask, right? We'll explain it if they ask. But what we need to now start asking ourselves is, would I be okay in this exact moment if this was photographed, right?
Man, listen.
It's going to be more objective. And, a lot of times our facilities rely on personal relationships with surveyors, that sometimes we get a little grace because of that. But now, with the objective survey, pictures, the objective documentation that surveyors have, they have to take that back to the team, and that is definitely going to hold more weight than a rationale that we've provided on site. So
you see what I got highlighted on the screen.
Yes.
You want to go?
Oh my God. Yes.
Surveyors may use photography as a tool supplementing written documentation to assure accurate and effective records of observations made during the survey, with intent to produce photographs that are relevant to possible deficiencies. I think people gonna miss that. I think people gonna miss it, and they're gonna be surprised when they get that 2567. and they're gonna spend all this money trying to find an IDR, and then these people gonna show up with the receipts.
Yeah,
show up with the receipts. So this talks about the importance of a mock survey, right? And that's something that I do, right? I own mocksurvey.com, the nationwide mock survey company. Mock surveys, are they optional? Are they negotiable? Or is it non-negotiable at this point?
It's non-negotiable. Like you just said, survey readiness is 365 days of prep. It's non-negotiable.
Yeah. So are the days of waiting for survey to find it? Is that is that how we should be operating, or how should we be operating as leaders in this space?
Again, we live with this data every day. We live with these residents every day. We know our residents, we know our staff. You have the playbook. You just show, the QSO with the changes, open book test. There's no way that when survey shows up, we should not be ready, right? Because we have the data. So the same information that CMS have, we have, right? We have the data first. So and we deal with these residents every single day. So I'm very passionate about that. And so, survey is just, because there's no way that we should not be having great survey outcomes. And so it's important to me. I know it's important to you, and the software you're building is phenomenal in helping that. And so I'm excited for more people to be able to see that as a tool. But it's just, there's no way that we should not be ready.
Well, because if we don't have the supporting evidence, as we tell nurses, if it's not documented, it wasn't done. And so, they taking pictures to document it.
It ain't gonna be, we had it. They gonna pull it out.
This ain't. Imagine you IDR something and you go there and they say, hold on, let me exhibit A. Exhibit A. And they got your person who you IDRing with a glove, without gloves, doing something to break an infection control. Oh my God. I'm just saying.
Yeah.
So, that's the first memo, so much more. But the second memo talked about special focus facilities. Did you have a chance to look at that second memo?
Yes.
So the second memo, special focus facilities, ultimately, you can't just graduate anymore. You got to show substantial compliance. And have you dealt with a special focus facility? Have you oversaw one, been in one?
I actually have not dealt with a special focus facility, which is pretty surprising. In 20 years in long-term care, and I've worked at some questionable places, but I've never personally had to work at a special focus facility.
So I have worked with special focus facilities. They aren't fun. They are surveyed every 3 to 6 months. And now what CMS is saying is, let me pull up my notes. Now what CMS is saying is they're going to focus more on fall prevalence, staffing levels, complaint history when they're looking at identifying special focus facilities. Every state has a list of candidates. So you can be candidates for years. You can be a candidate for years and never be a focused facility. My job is to help you get off the candidacy list and not see it, but also help you not be a special focus facility. Now, one of the things that I have to do when I deal with special focus facilities is what we love to do: copy every single thing, treat every single thing like it's a plan of correction. Survey readiness is a constant state, so we're doing our own mock surveys. You can't rely for the state to come in, because what happens is denial of payment, termination of your CMS license, and they're getting a lot stricter. If you haven't read this memo, they're getting a lot stricter. CMS is now telling them to pick facilities with 2 or more falls or low staffing ratings or ratios. My DMP project was on falls. That's how passionate I am about falls. Facilities need to gain that same passion. Patients, let me be clear, they have a right to fall, but it's your job to protect them. So when they land, they don't hurt themselves.
Yes.
Where you get in trouble is when they start hurting themselves. They have these reportable injuries. Maybe there's a fracture. Maybe they are repeat falling, and you are only targeting the symptom, right? You're not really treating it, not really treating a person, right? So we've seen falls. Every day they get up at 3 o'clock and they fall. So your intervention is a fall mat. Did that really do anything?
Or the intervention is a therapy referral, which ain't gonna happen for a week, and they fall tomorrow and the next day and the next day. Oh my gosh!
What happens when
interventions are like my?
Well, what about the intervention was education on the BIMSA too?
Put up a sign, call before you file, and they can't read. They have impaired vision.
So look, this is what's going to happen. It's going to be a survey every 6 months, at least every 6 months, unpredictable. You better believe they're going to come off hours, especially if you have some staffing issues. They're going to come after 6 p.m. or before 6 a.m. And, they're putting owners on notice. They're taking facilities. They're putting, regionals on notice. They're referring their licenses to the board, right? So as a special focus facilities, there's no opportunity to correct before the citation. It's just, you're a special focus facility. We're not here to play with you. Here's the citations. And once again, the penalties is CMPs, which who can afford that? Denial of payments, directed plan of corrections, where they have you call people like me in to help fix it. Now, I don't want that for you, but I want it for SMK. Be clear. I don't want that for you, but I want it for Jim Scout. I want you to, we don't want it, but if you must have it, let me tell you who to call. So over time, it's going to increase, right? And now what they're saying, right? If a facility receives 2 immediate jeopardies while SFF, it's going to constitute termination.
Oof.
That's in the memo. That is in the memo. They can proceed with discretionary termination.
And that could be one thing. You could get 2 IJs from one instance. And so I know we're going to talk about F tags. But, the F tag we're going to talk about definitely could be rise to the level of an IJ after they looked at a fall, right? Fall could be the thing, but then they look at that care plan. And now they say you have failed to develop a comprehensive care plan for, your residents. So both of those could turn into 2 IJs off of one fall, right?
100%. And so how you graduate off of it is, one, right? You have 12 or fewer deficiencies, 2 consecutive standard health surveys with 12 or fewer deficiencies under E level, right? No life safety or EP plans, no IJs, no high tax, right? No G level citations. This is how you graduate off of it. I help facilities all over the world get off the SFF list. Can you do it yourself? Of course you can do it yourself, but you made the problem. If you knew how to do it, you might not be there. So, it's just me being honest. And that's the name of the podcast, as I mentioned, right? At times it will be brutally honest, and I'm going to be brutally honest. So before we switch over to our FTAG review, which you're going to graciously lead us into, once again, another word from our sponsor. is that video didn't load. Today's sponsor is Survey Guard. Let me take off that question right there. Boom, boom, boom. Show and hide. Today's sponsor is Survey Guard. Survey Guard is a compliance and survey readiness platform built specifically for the post-acute care space. It is designed to help facilities stop reacting to surveys and start managing risks before the surveyors walk in. Survey Guard brings mock survey, quality oversight, grievances, plan of correction, support all into one system, so leadership can see patterns before they become serious issues. It helps you document action, improve substantial compliance. This is not about replacing your team. It's about replacing binders. I got to think about binders. So if survey readiness feels reactive, fragmented, or stressful, Survey Guard is a system for you. I built Survey Guard because I had to close a building down here in Hawaii. It had 36 citations, 2 IJs, and a directed plan of correction. It cost us $1 million. Everything was in a binder until the surveyors asked to see the binder, and then we couldn't find that binder where everything was.
Oh my gosh. Oh my gosh.
Yeah, I know. Isn't that crazy? So let's get ready for my favorite segment of the week. And it is called the F Tag of the Week review. And today's F Tag of the Week is going to be brought to us by Jim Scout. You fix F tags. You write plan of corrections as your role as a VP through your consulting company. So talk to us about this week's F Tag.
So this week's F tag is F656, which is comprehensive care plan, developing a comprehensive care plan. And so, a lot of times people say, well, somebody's admitted they have a care plan. And so we check that off, right? But really what we're looking at is the content of the care plan, the quality of the care plan, the person-centeredness of the care plan, right? And so I find that F656 is rarely cited because staff don't care, but it's cited because systems don't show, right? They don't show clearly, consistently, or defensively what we're doing, right? I know a lot of us use different EMRs, electronic health records. We're using all that stuff and, click, click, click. They have templates. And so I found that even when I do care plan audits, the care plans have very generic, they just check the box, especially for goals, right? Because somebody's goals may not be the same as what the software suggests, right? So sometimes we have to go above. There is always an option in most softwares to create your own custom intervention, custom goals. And so just making sure that we individualize, implement, and follow through. So interventions. I'm very passionate about making sure that the interventions you have on a care plan are resident specific, and it's stuff that you're actually going to do. And so I've seen beautiful care plans, 20 pages long. They have great interventions, but it's stuff that the staff is not doing, right? And so that's how we get into that gotcha when state comes in and we get tagged for F656, failure to implement or implement a comprehensive care plan. Oh, it's there, but we haven't implemented it because we're not doing any of the interventions that we've listed, right? Or we may have identified some risks to the resident, right, through some of our risk assessments, but has that made its way to the care plan? We talked briefly about falls, for example, making sure that those interventions that you have for a fall is going to be something that is implemented right away, right? Something to prevent injury, prevent fall, depending on what your goal for this specific resident is. We want to have immediate interventions, right, for things like falls. Also, I feel like IDT collaboration is what's missing in a lot of facilities. And yes. You work with MDS. I'm MDS oriented, came from MDS. And so a lot of times when I worked as an MDS coordinator in a facility, I may have been the only person who did the care plan review, who contributed to the care plan. And I've had surveyors actually tell me, in this role, when I speak to surveyors, where's the IDT? I've seen that your MDS is the only person who signed off on the care plan review. They're asking those questions. And so it's just important to make sure that the IDT understands the importance of an IDT process. Now, of course, you may have an MDS person who's very protective over those care plans, and he or she can be the keeper or overseer of the care plan, but we definitely don't want them being the only ones who know how to put an intervention in, right? Because if I have a fall on a Friday night or a Saturday and I put an intervention in place, we just talked about surveyors coming in on Sunday.
Yes.
You're not waiting until Monday to put the intervention on a care plan, right? So we want to make sure that somebody, a nurse, knows how to put. We can always go back. There's a history button in there if we need to fix it or modify it, or she didn't add it right. We can always do those technical adjustments, but we want it there. And so I do see a lot of times that one person is like, I'm over the care plans, or maybe that person has been designated, not elected, not volunteered, but
voluntold.
Yes, told you're going to do the care plan, you MDS, or however that goes. But it's very important. I see most care plan citations come from lack of IDT follow-up. And then the things in the care plan, I actually worked with a building, and they had a survey, and some with the falls. And I think the surveyor asked the MDS coordinator, would this put the resident at risk? They're ding, ding, ding. They want to know, would this, if this wasn't updated on the care plan, would this put the resident at risk of more falls? And so, of course, the MDS person is, I guess, I don't know. I would just say, she said no. Okay, and I probably would have said no too, and gave them, some whatever. So she said, because no one looks at the care plans anyway. Those were her words. So we want to make sure the care plan is not just some thing that only the MDS people look at and state looks at. We want to make sure that we have the ability. I know in a lot of EHRs, there's the ability to add some of these interventions to the Cardex. So we want to make sure we train our staff. And so also them understanding Cardex care plan is sometimes used interchangeably, because we have had surveyors ask our frontline staff about care plan, and they may say, I've never seen the care plan, but they see the Cardex listed. And so they may not understand that a Cardex could be considered part of the care plan, right?
Facts.
So
you dropped so many gems. Maybe that's why it's called the Gem Scout. And that's what's the purpose of this podcast, right? It's about QAPI, compliance, leadership, and team readiness. And that's what I have down at the bottom of our screen, right? QAPI, compliance, leadership, and team readiness. And if throughout our whole podcast, you'd heard us mention each and every one of those core values that I think we both share when it comes to the post-acute care space. You started, and we're going to stay on the F tag that you said, but I want to talk about the chain, how this progresses, right? Because this progresses very quickly. And so what happens is it starts as this tag that you just called out, right? 656 is what you called out, which is a care plan tag, right? And you know what it progresses to next? You want me to tell you where it goes every time? 684, quality of care. And after quality of care, you know where it goes to next? You know what I'm about to say? I'm about to tell you where to go to next. It then goes to 689, accidents and supervision. There's the progression every single time. You see a care plan, you see POCs, care plans, quality of care, accidents.
Yes.
We should coin it like the trifecta. We see it, right? Because just like what you said, right? They say, if it's not in a care plan, could this lead to a fall? Well, now that's a quality care issue, which, if depending on how they write it, could be a standard of care issue. And then it leads to 689, which is accidents and injuries. So I don't want you to get that tag. I want you to be good. I want you to not have that issue. But a lot of people, unfortunately, will have that issue because they're not taking care planning seriously. Why do you think, people aren't taking care plans seriously, right? Because that's just, to me, it's the basis, especially as nurses. It's beating to our head, care plan, clear plan. But it's so, I think maybe because it's so easy checkbox, but why do you think we're not taking it seriously?
I don't think we talk about it enough, really, right? I mean, I sit in some clinical meetings and we may say, is the care plan updated? And they add something. But who have we also communicated to that we are changing or updating the care plan? Who are we the people who actually care for our residents, right? The frontline staff, how are they being notified of these changes? Then the input that we get. So you talked about data. I'm very data driven. And so, garbage in, garbage out, right? And so are we getting good information on our residents before we even develop a comprehensive care plan, right? Or we don't update the care plan. Residents ebb and flow. We don't take care of widgets.
Mm-hmm.
And so when we do an MDS, of course, it's a snapshot in time. That's that 7-day window from the ARD. But people do not stay stagnant. We have good days, bad days, things change. And so it's just important to make sure that we're doing those reviews, right? We do the care plan reviews at least every 92 days with an MDS. But then other things also
They're not
trigger.
ready to hear that.
Yeah, but then other things also trigger the need for a care plan review, right? If somebody comes back from the hospital, a lot of times what happens is if we don't need to do an MDS, we don't review the care plan, right? Oh,
Yep.
They didn't come back with anything new. They're not
But
skilled. So we
Yep.
don't have to do a new MDS. We don't have to do a new assessment. But people change when they come back from a hospital, especially an extended stay hospitalization, right? And so, or those things like a fall, those things like new medications, those things like a new skin area, ADL declines, right? And so
Yep.
those type of things, if we're having communication with our IDT team, those need to be reflected in the care plan, right? Especially ADL care plans, right? Because that's how your frontline staff care for your residents. That's what we feed to the Cardex. That's what we feed to the POC documentation.
Facts.
That's what they're looking at. And so if that's not being updated, right, it's going to be hard to defend anything that happens because that care plan was an update, a fall, because you didn't read that the person is now dependent for transfers, and you went in there by yourself and transferred somebody, and the resident fell and sustained an injury.
What you think about my picture I got on the screen? Is that it right there? Can you see the picture?
That's it. I mean, we like here. I don't know if they don't. We didn't plan this. We didn't do a pre-run. But we are literally just on the same page because we see the front lines and the issues that are going on. This is exactly what I'm speaking to. Exactly.
So, right, care plan failure. You called it out. They get in that room. They transfer Miss Jones, who's now from a 1 to a 2. The resident impact, there's a fall. There's a decline. Then CMS says, you know what? I'm going to get you for 656. I'm going to cross tag you to 684 quality of care. And I'm going to give you an IJ because you sustained the injury on F689.
Right.
Type of kid. So, listen, it has been a pleasure. It has been an hour, by the way. I don't know if you know that.
I could talk, I love to talk. I could talk about this all day. I geek out on this stuff, and I love talking to you about it because we share the same passion. And I would talk to my husband about this stuff, and he'd be looking at me like, okay, but he don't understand. So I enjoy speaking about this stuff. I'm very passionate about quality care, and I just thank you for sharing your platform with me.
Listen, I think I told you we need to make this a permanent thing where me and you are doing it. How do they reach you? Drop that ebook location because you released that ebook.
I am the Gym Scout, so you can go to veronicaceaser.com to kind of get some more information on how to contact me. The website is newly done, but I'm still adding stuff every day. There is a survey ebook. I actually will drop it in the link of the live. At the end of this, I'll drop the ebook. It's a free ebook. It's called the Gym Scout 12-week survey readiness. And so it's 12 weeks, but then at the end of 12 weeks, you start all over. It's literally a continuous.
You copy that, couple that with the Quappy ebook that I designed as well. Put it right with yours, and let's get it out there. We're gonna drop it. We're gonna drop it in the chat. This is streaming right now on LinkedIn. It's streaming right now on YouTube. Within 48 hours, I will have it on all social media platforms. I want them to reach out to you for all things MDS, all things survey readiness. They can also come over to SMK Medical, reach out for all things survey readiness, reach out to all things MDS. This is not a competition. We just want to see buildings win.
Yes, because when the buildings win, our residents win. We have to make sure our residents are taken care of. And so as we start the quality improvement process, the survey readiness journey the continuous journey,
Mm-hmm.
it's a win for our residents. And so at the end of the day, everything that I do, everything that we do is for the residents. It's focused on the residents. And so there's no losers if we're on a quality improvement journey, on a survey readiness journey. And so, yes, thank you for that.
So I appreciate you coming on, and special shout out to our sponsor once again, SurveyGuard, for making this happen, the AI compliance platform designed for the post-acute care space. So as we wrap up this journey, I want to thank each and every one of you guys for listening to this podcast, viewing this podcast. This is the first inaugural episode of the Survey Readiness Podcast. This podcast is produced once again in collaboration with SMK Medical and SurveyGuard, organizations focused on strengthening leadership, compliance systems, and survey readiness across the post-acute care landscape. The views expressed on this podcast are for educational purpose only and do not constitute legal or regulatory advice. Regulations change, surveyors interpretation varies, and listeners should consult appropriate professionals when making operational and compliance decisions. If this episode helped you, it helped you think differently or prepare earlier, subscribe, share it with your leadership team and anyone else that you know. You can follow us at the Survey Readiness and follow me on Instagram and TikTok at your healthcare consultant. Until next time, stay ready, stay survey ready.